So here we are starting our unit on mitral regurgitation, which is part of Unit 3, the very first part. We're going to be discussing mitral regurgitation and pulmonary hypertension in the first few videos. Some highlights: common causes such as LV remodeling, the phase changes of mitral regurgitation, that's what we call them, hemodynamic consequence of pressure or volume overload, and how we, by echo, quantify the amount of mitral regurgitation. It's the most common valvular lesion in the U.S., over 7.5 million. That was in 2014, so many more beyond that. And it's expected to double by the year 2030, so job security. When you look at the mitral valve and how we break it down, how the surgeon breaks it down, you can see it has a line of coaptation between the anterior and posterior leaflets. Then the leaflets are broken down into sub-leaflets, so to speak, where you have A1, P1, A2, P2, A3, P3, and so on and so forth. And we're going to kind of look at how, by echo, we actually, in the imaging that we take, we actually demonstrate to the reader which valve leaflets are potentially more affected than the other. If you look at this slide here, you can see where we see anterior, posterior, and so on and so forth in each image. And then you see up here, you see the surgical view, or the surgeon's view of the mitral valve when he or she is operating on the patient. And what's notable here is everything is just essentially reversed from our view and the surgeon's view. So if you took this view and just flipped it around, you can see A1, A3 over here. If you flipped it around, A1 in our view would be over here, and A3 and P1, P3. So when we do a 3D imaging of the mitral valve and transesophageal echo, which some of you may or may not be doing, to look at the leaflets more carefully, we actually capture the 3D image and reorient it to the surgeon's view so that when we send that image out, it will go out in that manner so that the surgeon can more clearly see which leaflet may be and which subleaflet, so to speak, cusp may be more intricately involved in the surgery correction. So when you look at our views, for example, in the transesophageal view in the long axis, we see leaflet A2 and P2. So if you go back to this one here, we're cutting through sort of like this right here in that view. We're actually seeing A2 and P2. And then you can actually scan, tilt down a little bit or up a little bit. Tilt up a little bit, you'll see A1, P1 kind of come into the picture, and you can still see the aortic valve there. And then if you angle down a little bit towards your right ventricular inflow, you'll see A3, P3. And then when you, like I said, when you go into the short axis view, A1, A2, E3, P1, 2, 3. And remember, that's what I showed you on the 3D image here, where it's flipped over for the surgeon. A3, A2, A1, P3, 2, 1. And for us, it's just the opposite of that in the short axis view. And then if you go into the 4-chamber view, you'll see A3, P1 primarily. A2 may sneak in there, and then P1, P3, and the 2, where we're going right down the middle of the valve, and that would be right here in the 2-chamber view. And that would be the same, either transthoracic or transesophageal echo, or kind of right down to the middle of that coaptation point. And by looking at all these doing all these angles, the doctors can more adequately assess the valve in which cusp may be more affected than the other, where the problem is, so to speak. So this is just a transesophageal look at that, and you can see the angles where I was in the certain views and where we're cutting down through these different leaflets, and you can kind of emphasize here in the 2-chamber view where we're seeing the right down the middle here, the coaptation of the 2 leaflets, and where we're just like kind of like just the opposite of that in the long metasophageal long axis, so cut right down through the middle of the A2, P2 leaflets. And then if you go into the 4-chamber, we're kind of cutting across this way here. So all these views give us a better analysis of which part of the leaflet, be it anterior posterior, is the issue, and whether that can be clipped or needs to be surgically repaired, or whatever they decide to do. So before they did ultrasound, they didn't realize that the valves were more apt to leak, at least trivial physiologic leaks versus, major leaks. But they didn't really realize that until ultrasound became part of the game, where okay, well, you scan enough people and you find out, first you look at it and you say, this person's got a leak, ooh. Well, you scan enough people, and over time, then you realize that, well, it's actually more common to have a mild leak, trace leak, physiologic leak, than it is not. You very, very rarely see anybody who comes through the lab that has absolutely no leak at all. That's outside the norm, so to speak. But so up to about 70% of adults have at least a trivial amount of MR, and a moderate to severe is far less in the population. Those are the ones, of course, we're managing. And we do have primary and secondary causes of MR, and the doctors will relate to the surgeon. Of course, they know what the causes is, but if you just, by definition, the primary MR is a disease of the leaflets or cords, where secondary is caused by a disease of the LV or LA. So it's secondarily caused by either chamber enlargement of either one of those or whatever. But primary is a disease of the mitral leaflet or cords themselves. And then that's broken down into, structural, functional, where structure would be primary, if you will, and then functional would be secondary by this definition. You have mitral valve prolapse is probably the most common structural problem with the mitral valve. Carditis, rheumatic fever, which we don't see too much in the U.S., although I do follow a patient in our lab. Who's a friend of mine, actually, and she has rheumatic MS. Some sort of congenital heart issue, maybe, or a heart attack, muscle injury, where a pap is taken out and a cord is flail, or just kind of hanging out there. Some sort of trauma, papillary rupture, again with a heart attack, something like that. And then you have your secondary causes, annular dilatation through a dilated ventricle, or leaflet restriction, SAM. That's systolic annular motion of the mitral valve, enlarged atria for whatever reason, diastolic dysfunction, AFib, whatever. I'm sure we'll see some of this on the test. So under moderate to severe MR, the LV is likely to remodel, and that can happen one of two ways. If it's not MR, it can happen physiologically with or MR or MS. But we're talking about mostly MR. It can be a physiologic remodeling with athletes, and with that athletes, a compensatory change in proportions and functions, as it says there, happens. So if you see dilatation, maybe slight dilatation in an athlete, but everything sort of stays it stays relative to one another. Like if the walls thicken an athlete, then the ventricle will also enlarge, which stays sort of relative to the size of the heart, whereas in hypertension, the walls just thicken and the heart actually gets smaller because the wall thickens. The heart isn't enlarging. The pathologic pathway, however, pressure overload due to an infarction, inflammatory myocardial diseases of some sort, which are listed here, dilated CM, some sort of volume overload is going to cause the LV to remodel. To look at the pathologic pathway, with chronic increases in demand, such as an MI, this will occur. The majority of this process, as it says here, is irreversible. A chronic overload causes an inhomogeneous contribution of fibroblasts or collagen buildup in the muscle. And this causes some sort of fibrotic process to start in both infarct and non-infarcted regions. So when they have an MI, that's not good. It's going to cause some sort of damage to the LV, and the LV is going to therefore remodel to some extent in some way without that muscle activity going on. Whereas with physiologic remodeling, it's going to stretch. We've heard about the Frank-Starling mechanism, right? Stretching, increased volume. The heart will enlarge and thicken in some, primarily in athletes. So the actual myocytes of the heart expand. New contractile proteins are laid down, and so on and so forth. And the contractile force increases, and this is a homogeneous process, leads to an increase in the myocyte and exercise-induced response. This condition is actually reversible. So if you were to be an incredible aerobic athlete in your younger years and did nothing after that for quite some time, the heart would just come back to normal. Whereas in the pathologic process, this whole change is basically irreversible. Sometimes we run into situations where, and you and I are probably not going to run into this, but if you do somewhere in the future where they do studies on athletic populations and what have you, you may run into a situation where you see somebody with an athletic heart, and it looks something like hypertrophic cardiomyopathy. But as I said, the heart of an athlete is a physiologic process. Everything's going to kind of change in relative to the other parts of the heart. For example, the heart walls thicken, the heart itself is going to dilate in an athlete because of that volume increase. And the stroke volume may actually be a little bit down in a highly athletic person. And the reason being is that heart is so responsive when it pumps. It maintains a proper stroke volume without contracting too vigorously at all, although that will, of course, go up with exercise. But this here basically does identify some variables that differentiate hypertrophic cardiomyopathy from an athletic heart, and it shows you what's positive and what's negative amongst those the different HSAs too. If like the LV cavity less than 4.5 in hypertrophic cardiomyopathy, it's going to be a small cavity because it's going to be thickened. Whereas an athlete, you don't see that cavity size decreasing, you see it actually increasing. So you can see it here, LV cavity greater than 5.5 positive. So if you look at the positive things here, in hypertrophic cardiomyopathy, thickness with deconditioning and so on and so forth. So, and of course the VO2 in an athlete's going to be much higher than it is in a somebody who's got a sick heart. So you don't really know that till you treadmill test them. But for those people that do the exercise science stuff, which used to be my love, if they do a VO2 test, obviously the athletic heart's going to be superior in that regard. There are different types of hypertrophy. I think I mentioned this earlier on in the course. So when the heart hypertrophies, we do have different types with moderate to severe MR, which this will be on the test too. So with moderate to severe MR, which hypertrophic response happens? Which thickening happens? Concentric or eccentric? And the answer is eccentric hypertrophy. Concentric comes after. So eccentric is the stretching component of that. And just like you would exercise a muscle, if you were to use an eccentric form of exercise, for example, you struggle to do pull-ups. So what you do is you stand on something, hang, and let yourself slowly go down in an eccentric force on the muscle, stretching the muscle rather than contracting it, but holding that force against it. That would cause a certain degree of eccentric hypertrophy as opposed to pulling yourself up, which causes concentric hypertrophy. However, when you do your reports, you're not going to see any mention of eccentric hypertrophy. It's sort of a, I don't know, sort of like it's just not there. So most reports we do, we always say concentric hypertrophy. And here's this just showing what happens with those two different types of hypertrophy and what causes them. So if you have a hemodynamic overload causing heart failure, if you have a pressure overload, you'll have concentric hypertrophy. And if you have a volume overload, you'll end up with eccentric hypertrophy first due to an increased preload. And this pressure overload and concentric hypertrophy is due primarily to an increased afterload. So hypertension and AS are examples there, whereas MR and AI are examples over here. Probably good to know that for the test purposes, the difference between eccentric and concentric hypertrophy and which overload causes either one. We have three changes to the mitral regurgitation process, so 3 phase changes we call them. We enter, first one we come upon is the compensation phase. Transitional phase would be next, and then the decompensation phase, which is going to happen if we don't treat that MR. In the compensated phase, the LV undergoes some changes. Again, undergoes what we were talking about earlier, eccentric hypertrophy due to the volume overload. So therefore it enlarges. It becomes more compliant, and due to that Frank-Starling mechanism, that helps maintain the stroke volume. And the left atrium enlarges too. And remember, we got MR going on, so that's going to accommodate a large backflow. Help accommodate the larger than normal backflow into the left atrium due to the MR. And at this point in the disease process, minimal elevation in the left atrial pressure, and function and PA pressure are pretty much normal. They may like borderline or something like that. And the patient is primarily asymptomatic at this point in time. When they enter the transitional phase, the LV, as you can see, begins to weaken. However, the EF may remain the same or maybe decrease just a little bit. LA pressure begins to rise, compliance starts to decline some, The LA pressure increase is believed to be the initiating factor in the pathogenesis process of the beginning stages of pulmonary hypertension. So pulmonary hypertension, if you look it up and look at the sources, is 70%, probably more than 70% of the time, 70% plus the time, it's a disease of the left ventricle, the left heart, where pressures are just backing up into the lungs, causing essentially congestive heart failure. Pulmonary hypertension is also a disease of the lungs, but that's primary pulmonary hypertension, which is much more uncommon than hypertension caused by pressure back up into the lungs due to a disease process going on the left side of the heart. Sounds like that might be on the test. And then we have the decompensation phase where the LV is going to enlarge, the function is going to go down. The LA is getting very large at this point. Abnormal heart rhythms possible due to that LA enlarging, such as like AFib. Blood pressure in the pulmonary arteries is going to increase. Remember that blood's going backwards, that pressure is going backwards into the pulmonary system, into the lungs. And over time, changes become, if not treated, become irreversible, and signs of congestive heart failure develop. So why don't we stop there and continue on with another video in just a few minutes.